Hello, I'm Hyunkyung a PhD student at Brown University. I'm going to present about using the electronic medical records of nursing home residents for improved measure of behavioral symptoms. First, I want to acknowledge my co-authors and mentors, Dr. Vince Moore and Dr. Ellen McCready from the Brown School of Public Health. So, at some point of disease course, nearly half to over 80% of people living with Alzheimer's disease and related dementia will experience agitated behaviors. And these symptoms may affect the quality of life or safety of not only those who are experiencing these behaviors, but also other residents or caregivers in the nursing home setting. And also they can contribute to the burnout of nursing home staff. So it's important to accurately identify the behaviors among nursing home residents for policymakers and researchers so that we can understand the size of the problem in the nursing homes and also correctly examine the effect of behavioral management strategies. So interventions to reduce behavior problems are increasingly using embedded pragmatic clinical trial designs, and these are typically relying on routinely collected data in the nursing home setting, minimum data set, to ascertain the outcome. However, there's a concern that MDS assessments significantly underestimate the prevalence of behaviors among nursing home residents compared to the gold standard behavior assessment tools. So structured or unstructured EMR data may lead to better identification of behaviors in nursing home residents with ADRD for the evaluation of the pragmatic trials outcomes without additional data collection. So our study aimed to compare the prevalence of behaviors as measured by MDS only and also as measured by structured and unstructured EMR data in addition to MDS. So we used MDS assessment data and EMR data provided by one large corporation that is ranging from January 2020 through August 2022 for 32 months. And our study population included long-stay nursing home residents with ADRD, and ADRD status was determined based on the MDS checkboxes and their related ICD-10 codes. So we compared the three agitation measures. First, it was MDS. So agitated behaviors identified by MDS were based on 4 types of behavioral symptoms in the past week, so during the past 7 days. Physical behaviors toward others, verbal behaviors toward others, and other behaviors not directed toward others, and rejection of needed care. Responses to these 4 items were summed up to construct the agitated and reactive behavior scale, ARBS, which ranges from 0 to 12. The proportion of residents with ARBS greater than 0 were considered the behaviors identified by MDS. And second, it was INTERACT, the structured EMR data. So intervention to reduce acute care transfers. INTERACT is a suite of provider tools aimed at improving early detection of changes in behaviors among nursing home residents. When fully adopted, it is likely associated with a decrease in potentially avoidable hospitalizations, and many nursing homes have integrated these tools into their EMR. So we used behavior data from INTERACT SBAR communication form, which is embedded in the nursing home EMR, and it has 3 yes or no items to document the increase in resident agitation, verbal aggression, or physical aggression. The proportion of residents with any increase in behavior indicated on their e-interact forms were considered the behaviors identified by structured EMR. And third, it was physician orders, the unstructured EMR data. So we conducted keyword searches of these free text physician orders, which document behaviors to justify one-to-one or increased supervision, medication use, or restraints, or to request a psychiatric consultation. The keyword search algorithm indicated orders based on 36 keywords. And the findings were manually reviewed, and the error rate of the algorithm and the variations tested are included in the appendix slide at the end. So the proportion of residents with order documented behaviors were considered behaviors identified by unstructured EMR. For the analysis, we first identified nursing home residents with ADRD who had a routine MDS assessment in a given month. And then we pulled all the interact and orders for those residents in the given month. And the analytic data were organized at the person month level, and means were used to report the prevalence of behaviors by sources. We also considered variation in the use of EMR data for behavior captures across nursing homes. Then we assessed the overlap and independent behavioral reporting across the data sources. So now let me share our findings. So we identified 77,936 MDS assessments for the 19,705 long-stay nursing home residents with dementia from 322 nursing homes. And overall, demographic characteristics were consistent with the national population of people living in nursing homes. And this shows the gains in the identified agitated behaviors using structured and unstructured EMR data versus nursing MDS alone, and as monthly trends from January 2020 through August 2022. The blue line represents the proportion of long-stay residents with dementia who had behaviors documented in MDS in a given month. And the orange line shows the proportion of residents with behaviors identified by MDS supplemented by the structured EMR. And the red line represents the proportion of residents with behaviors identified by MDS supplemented by both structured and unstructured EMR. So as you can see, although there are some variations in the magnitudes, MDS supplemented by EMR data presented gains consistently in behavior detection over the MDS identification only during the study period. So on average, the percentage of residents with identified behaviors increased from 14.8% using MDS alone to 16.2% using structured and MDS, structured EMR and MDS, representing 9.5% relative increase. And it increased to 18.6% adding the two EMR data, structured and unstructured, in addition to MDS. And this represents a 25.7% relative increase in detectable behaviors. And then we stratified nursing homes into two groups based on the use of structured and unstructured EMR into moderate and high use groups to determine whether the gains in behavior detection by EMR were driven by variation in the use of these forms across nursing homes. Similar to the findings for the total sample, EMR increased the average detection of behaviors, but the increase was larger in the nursing homes with high use of EMR. For example, in nursing homes with moderate e-interact use, which is structured EMR data documenting behaviors, supplementing MDS with the two EMR data resulted in a relative increase of 25% compared to MDS alone, but it was 28.4 relative percent increase in nursing homes with high use of e-interact forms. And then we chose 1 month of the data to examine the overlap in behavioral reporting, behavioral identification reporting across the data sources. And as you can see here, there was less than 1% overlap across any two sources, and only 0.2% had behaviors identified, recorded in all three sources. When we looked at the behaviors identified by interact and orders in a given nursing homes, the average proportions of eligible person month with behaviors within nursing homes were inconsistent across nursing homes. And it shows the variations in the use of EMR to capture agitated behaviors across nursing homes. So we found that using structured EMR in addition to the MDS resulted in about 10% relative increase compared to what was detected by MDS alone. And using unstructured EMR in addition to MDS resulted in about 17-18% relative increase. So altogether, use of structured and unstructured EMR data in combination with the MDS resulted in a relative increase of 25.7%. But interestingly, there was not much overlap in behavioral detection across data sources. And this suggests that these data sources may be capturing different types of behaviors. And in fact, the goal of structured EMR Interact is to communicate a problem to the medical director and to elicit a response. So it is more focused on an acute change in conditions. Whereas the goal of unstructured EMR data, your physician orders, is to justify ongoing medication use or to request additional services such as consultation with doctors or transfer to hospitals. So it may represent more severe or currently medically managed behaviors. And MDS behavioral items are completed for all residents, so it is independent of severity and it's not related to the change in conditions. So interventions to reduce behaviors among residents should be carefully targeted to the type of behaviors that researchers are interested in modifying. And the behavioral measures should be chosen following the intent of the intervention. For example, evidence suggests that verbal and physically non-aggressive behaviors are the most affected by the non-pharmacological interventions applied in the pragmatic trials. And these type of behaviors may be better captured by the routinely collected data, MDS, such as MDS. On the other hand, aggressive or disruptive behaviors may be the important targets from the policy perspective. And these types of behaviors may be better captured through e-interact or orders. There are some limitations that should be noted. First, MDS documented behaviors, those items ask for a 7-day look-back period, whereas EMR forms are not restricted to a specific look-back period. And our results should be replicated in other corporations and other EMR systems for the transportability of the algorithm. And also, we need to carefully think about how we can ethically use these data by understanding whose outcomes are represented and who is systematically missing. And lastly, our data overlap with the COVID-19 pandemic period, so this could limit the generalizability of our findings. In conclusion, the use of structured and unstructured EMR data in addition to the MDS could augment the detection of agitated behaviors, which reduce the quality of life of residents and contribute to the burnout of nursing home staff. And our findings also have implications for better targeting and evaluating the effect of behavior management strategies. So with this, I would like to end my presentation. Thank you for your attention.
I have a question. Yes. Thank you for this. Given that your 3 graphs basically follow the same trajectory entirely,
Yeah.
It sounds like that the MDS captures difficult behaviors, and they may be routine difficult behaviors for any group of residents, and that the E-Interact is the reporting of that to the physician, of course, and that's a higher level capture of the same data, maybe different by intensity of the behavior, and then the charting from the physician that is just yet another third data point of probably the same thing, but varying by intensity, now requiring probably unfortunately a medication response or a service response. But basically, you're describing the same clusters of behaviors, but with different levels of severity. Is that right?
Yeah, we are interpreting these findings in that way,
Okay.
yeah.
All right.
Do you think that you will have different conclusion for race-specific and sex-specific populations?
I'm sorry, could you repeat that?
So, do you expect differences in your conclusion if you consider just separately white, black, male, female population?
I didn't discuss it here, but we discussed in our team that because, like, for example, there is a correlation, findings about the correlation between EMR usage and nursing home quality, and nursing home quality is also systematically related to the racial disparities. So yeah, we thought there are some linkage mechanisms. Yeah.
Thank you.
Thank you.